Now we're recording our session this morning. So welcome to AHI. We do have a few items to cover. The session's being recorded, so don't include any confidential patient health information during the session, particularly during any case consultations. On screen now is how to connect to audio using your phone. If you're having any issues with your computer, please mute your computer mic and speakers and connect through your phone if you're having trouble. Otherwise, you're good to go. *6 will mute and unmute on your phone, and I can mute you if needed. Please don't place us on hold or we'll all hear that music. Cameras are enabled. We love to see you on camera. We're here on camera, so please also join us. So click on the camera icon and start my webcam to make that happen. Our disclosure and accreditation statements are on screen right now. We don't have anything to disclose today. Our case consultations, we do have a partnership with Molina and Blue Cross Blue Shield, New Mexico's Centennial Care, to get you reimbursement for bringing your cases to us. So take advantage of that. Just get in touch with us for more information on that. Michelle Widener or myself, and we'll get you information. It's $150 to about $80 to get reimbursed for that. And this is our opportunity to say your name and let us know you're out there and where you're from in order to be eligible for CME or CEU certificates. Let us know that you're there, either by stating your name or writing it out on the chat box. And a number of people have done that. We'll go around the room.
Sure, we'll go around the room. I'm Caitlin Adams. I'm the facilitator for the Adolescent Health Initiative, and I'm also a quality improvement coach here at Envision, New Mexico.
I'm Amy Smith. I'm an assistant professor in departments of dermatology and pediatrics at UNM.
I'm Julie Brockmeyer. I'm a nurse practitioner at urgent care at UNMH.
I'm Elena Scher. I'm senior statistician at Envision, New Mexico.
McKean Sharf. I am program manager for the School-Based Health Center Quality Improvement Program here at Envision, New Mexico.
Brandon Bell, just off screen. I'm another quality improvement coach here at Envision, New Mexico.
Great. Well, we will go ahead then and get started. We will turn it over to Dr. Amy Smith, who will be talking about acne today.
Okay. So as providers who see adolescents, clearly I think we are all familiar with acne. The purpose of the talk and the discussion today is to really just familiarize ourselves with how best to categorize acne and therefore how best to treat it. And I would like this to be, as interactive as possible. So please jump in with any questions or if anything's unclear. So I thought we'd start off with just a sort of pre-test, post-test kind of scenarios. So in this case, this is a young girl. She's 11 years old, and she comes in with both forehead and sort of T-zone acne, so affecting the glabella, the perinasal area, and the chin. And she's already tried benzoyl peroxide from the drugstore without benefit. And she has no other areas of involvement on exam. So the question here is, how would you treat? And I want you to kind of keep your answer to yourself for now, and we'll revisit this at the end. But the options are A, salicylic acid, B, a topical benzoyl peroxide clindamycin combination, C, maybe adding in an oral antibiotic, or D, referring to dermatology. The second case is a slightly older boy, 16 years old, and he has more involvement on the face and trunk. He's already using an over-the-counter wash and topical erythromycin, and he tells you that this is a good day and everything is making him dry. He's very frustrated with his medications. So in this scenario, what type of acne would you classify this as? A, mild comedonal, B, mild inflammatory, C, moderate to severe mixed, or D, severe nodulocystic. Again, keep your answer for the end. And then lastly, a similar aged boy, 17, but he's had acne now for already several years. And a partner in your group has already started him on oral minocycline, as well as a combination of benzoyl peroxide clindamycin, and he's had no response. So in this case, what type of acne, how would you categorize, and how would you treat? So in terms of acne, we all know it's very, very common. It's actually the most common skin disorder that is seen in the U.S., and it affects a vast majority of the U.S. population at some point in their lives. So 80 to 85% of individuals will have some form of acne during their lifetime, and obviously it's usually during the adolescent period. But aside from the actual, acute episodes of acne, there's other long-term effects. Such as permanent scarring, perhaps, and psychosocial withdrawal or decreased quality of life when people are affected. I really do believe that the majority of patients with acne can be treated in the primary care setting with first-line therapies, and the minority really, need referral to specialists, dermatologists. But there's no gold standard treatment. It really needs to be individualized based on the type of acne, and that's what we're going to go through today. There is a familial tendency, especially to more severe inflammatory acne, and some have posited that may be an autosomal dominant type trait. It's not unusual to see a teenager with severe acne whose parents show, evidence of scarring or have needed aggressive treatment in the past. The typical adolescent acne for most of us will begin, in that pubertal onset time or perhaps slightly earlier. And girls, as we know, 12 to 13, a little bit earlier than boys at 14 to 15. And it's not unusual to see what people call pre-adolescent acne, i.e. acne at 8, 9, or 10 years old. And that does not necessarily warrant any specific concern. 50% of the population who's affected with acne as a teenager will still have acne into their 20s. So it's not something that's just going to be during that time necessarily. However, if you do have someone who presents with a specifically earlier onset or a later onset, i.e. they've never had acne before, and then as a, say, 30, 40-year-old woman may develop acne, we would want to think about things like androgen dysfunction. There are other triggers for acne and acne flares. Stress can trigger any skin condition, but definitely acne specifically. Hormonal fluctuations and flaring with menses is an important thing to ask about because it might affect your choice of care. Mechanical or occlusive type factors, so people can break out in areas that are rubbed frequently or occluded because of the sweat, i.e. sports gear, helmets, hair products, and if they're wearing makeup that is comedogenic. We'll go into that a little bit later. There can be also medications that can trigger more severe acne flares, so important to keep in mind things like anabolic steroids, the illicit use of progestin use, so the progesterone-only contraceptives can flare acne, and then lithium and tuberculosis treatment as well. I mentioned PCOS. In an adolescent, you'd want to think about that as well if it's in the right scenario. And then diet. This comes up all the time with our patients. They want to know what should I eliminate from my diet in order to get rid of my acne. And the evidence really is not strong in terms of any specific dietary component, but there are theories about, the milk additives in milk, perhaps hormones that get added or antibiotics that get added. So that can be a factor in some patients. And then there's also this theory, which I personally find very intriguing, about pro-inflammatory nutrition and high glycemic index type foods, refined carbs, for instance, that might trigger an inflammatory response in a susceptible individual. So going back to what causes acne, I think it is helpful to remember the steps of pathogenesis of acne so that we can, again, target our treatments appropriately. So the first step really in anyone with acne is obstruction, or basically clogging up of the pilosebaceous unit. So that tends to be like the waxy, sort of oily, dry, dead skin that all of us shed every day, instead gets clogged within the pore itself. Then you have increased sebum production, especially around the time of adolescence, right? Because of the hormonal influence, increasing oil production within the gland itself. And then bacteria, which are typically on the surface of the skin, really like that milieu. So they come in, they set up shop within that oil gland and the follicle, and then they proliferate. And that's Typically, the bacteria known as P. acnes, which doesn't tend to be pathogenic or cause true infections, but in, again, a susceptible individual can proliferate and cause then inflammation. So that's where I was mentioning perhaps this is a genetically determined population that is more hypersensitive to that bacteria. So what does that translate to clinically? I don't know if I should use the pointer here. Does that work or not? Okay, no pointer. So clinically, that first step, that clogging up of the pores, so to speak, would clinically translate to comedones. So blackheads and whiteheads, because the pores are just sort of getting clogged and they're either open or they're closed. Once the bacteria set up shop and proliferate, and then you have a little of an inflammatory response, that's when you're going to see pink papules or perhaps pustules. And then the severe variants that I've listed are shown here on the right are just the more aggressive forms of both of those things. So up on the top right, we have someone with severe comedonal involvement, and on the bottom, more severe inflammatory involvement. So again, it's important to categorize what type of acne is it, comedonal, inflammatory, or both, and which the severity, are we mild, moderate, or severe? Then the other questions that I always add are if it's a young woman, are they flaring with their menses, and therefore could it be hormonally related? Do they already have scarring, or are they at risk for having scarring? Is there an impact on quality of life? So even if it's potentially mild acne, objectively to you, if the patient says that they don't want to get undressed in the locker room because they're embarrassed, they're not participating in sports, they're not going out with their friends, that would sort of bump up your severity for those reasons. Truncal involvement is also an important thing to assess, because mostly they're going to be talking about their face, but if they have truncal involvement, it also sort of bumps up the severity in terms of how you're going to be able to treat it. And I always ask my patients, is this a good day, a bad day, or an average day? Because sometimes they're frustrated. They come in and they're like, this is the best I've looked for months, and it took me so long to get into you, and this is not how I usually look. So asking them that can be helpful as well. I just wanted to put a slide in about sort of the most severe form of acne, which would be called acne conglobata, or if it has systemic symptoms associated, then acne fulminans. So this is the most severe presentation. We're typically going to see this in teenage males, and it's really defined by these multiple deep draining connecting sinuses and tracts. It just most definitely leaves scarring. Most patients, by the time they present with this, already have scarring. And then, as I mentioned, they can have systemic symptoms such as low-grade fevers, malaise, even bony pain, specifically in the sternum. So there can be sort of rare autoinflammatory syndromes associated with this, and it warrants really aggressive treatment and urgent referral. Another category to be aware of is called acne excoriae, or de jeunes filles, of young girls. And this is best understood more as a factitial dermatitis, i.e., there may be mild acne there, but what you see is evidence of picking and manipulating, and these people just can't stop from that behavior. So we're often seeing this in the setting of perhaps mild anxiety, obsessive compulsive traits, or body dysmorphic disorder. So I think it is important to recognize and not over-treat for the potentially inflammatory component here. I often do give they're typically young women, topical medications so they're able to do something for the active acne, but it's really important to recognize the behavior and get them to the appropriate resources, i.e. usually behavioral health specialists. So I mentioned the categories and how we would want to approach every acne patient, and then the reasoning again is to best treat them with our options. So this is my algorithm in brief. If it's mild comedonal, I would typically choose a topical retinoid and salicylic acid, and we'll go over all of these medications one by one. If it's mild inflammatory, I would typically treat with a combination topical therapy, including benzoyl peroxide and an antibiotic. If we're more in a moderate category, I'm going to be adding in an oral antibiotic and perhaps thinking about a hormonal option. Similarly, for this more severe inflammatory, I would definitely, start full press with a combination regimen and consider the hormonal component in the young woman. If it's severe, we have a low threshold in dermatology for considering isotretinoin at that point. If it is primarily hormonal, an OCP or the hormonal components alone can be very effective with or without the topicals. And then if you have a patient who comes with severe nodular cystic acne from the get-go, urgent referral would be warranted at that point. Okay, so the medications one by one and sort of my clinical pearls, I guess I would want to say about them. Benzoyl peroxide we're all very familiar with. It's available over the counter. It's also available by prescription, but it is hard to get covered these days because of the availability in the drugstore. The actions of benzoyl peroxide that make it applicable to acne would include that it's antimicrobial, so it kills the bacteria, it's anti-inflammatory, and it's mildly comedolytic, i.e. it breaks up the clogged pores a little bit. It's not the best at doing that, but it does do it a little. The concentrations can range. We typically want to start relatively low, and it comes in a multitude of forms or vehicles, i.e. cleansers, creams, gels, etc. Some clinical pearls about benzoyl peroxide: it does bleach clothing, as is shown on the bottom there. So we always want to warn our patients and their parents to wash their hands well after using it. Get, cheap white towels instead of nice ones in the bathroom. Most of them know that already because they've been using it from the drugstore. The more common complaint is irritation, which can manifest as dryness of the skin, redness, or peeling, as is shown there on the right. Rarely you can have a true allergic reaction. So usually when patients are describing sensitivity to benzoyl peroxide, it's an irritant reaction, not a true allergy, but it is possible to have a true allergy. So in my practice, I always emphasize they just use a small amount. They use a thin layer. Patients nearly always want to overdo it because they want their acne to be gone, immediately. But I tell them you really shouldn't see it on your skin. If you're walking off to school and you have white streaks on your face, you're using too much. They can start every other day and go up to using it more frequently. And that's sort of a broad, nice recommendation to make for any of the topical medications so that their skin can get used to it. So again, I mentioned I usually start relatively low, maybe the 2.5 or 5%. And I usually advise using the wash in the morning or using a cream. Gels in and of themselves have alcohol in them. They're more drying. So combining the benzoyl peroxide itself with the gel can be too drying and irritating for the patient in some cases. Other topical considerations over the counter might include salicylic acid. So salicylic acid's benefits are that it reduces the oil on the skin. It is somewhat drying, but it's less so than benzoyl peroxide, and it's comedolytic. It breaks up the clogged up pores. And similarly, it comes in various vehicles, including washes and topicals that can be left on the skin. Relative of salicylic acid would include glycolic acid, which is an alpha hydroxy acid. This is actually, for your patients who want a more natural derived product. It is usually derived from fruit, so that can be a benefit. And it has similar properties to salicylic acid. Importantly, and we'll mention this at the end, it is safe in pregnancy, so that can be a nice option. Clinical pearls about these, these are available over the counter in many of the quote anti-aging products that are marketed to some of us older women. And so they can be a nice idea for teenagers who have more sensitive skin, have had really severe eczema, for instance, or have keratosis pilaris, and they can't tolerate the stronger acne stuff. Typically, though, these products are going to be more expensive, especially the glycolic acid containing ones. So that might limit the availability, the patient's ability to get them. But they also help with post-inflammatory hyperpigmentation, which are the marks, right, that get left behind. So that can be helpful. The topical retinoids are by prescription, right? And these function to normalize the keratinization, the skin cycle. They sort of speed it up. And they build dermal collagen, so it can be a helpful adjunct for scarring as well. But their main properties for acne include that they're comedolytic, they break up the clogged pores, but retinoids are actually also like anti-comedogenic, meaning they stop the process of the comedone forming in the first place. So they can be used very well as a preventive measure. Again, applying sparingly, really a pea-sized amount goes a long way. They need to apply these at night for two reasons. One is the sun inactivates the medication itself. So I always kind of explain to patients the tube that the medicine comes in is metal, and that's so the sun doesn't, penetrate to the cream itself. So you need to put it on at night, because if you put it on in the morning, you're sort of wasting your time. Similarly, retinoids themselves increase photosensitivity, so it's better to use them at night. And these are in general considered teratogens, but one of the handouts that I gave you that is included on the website does discuss that's a little bit of a controversial topic, i.e. there really have never been any birth defects reported with a woman using these topically. There are different strengths and different formulations of the retinoids, so going from the gentlest, which would be adapalene, to the strongest, which would be tazarotene, and in the middle is tretinoin. And these are all now available, both generic and brand name. They come in various different concentrations. So I usually start kind of right in the middle, 0.025 cream form, so it's a little bit gentler, as I mentioned, than the gel. If you have a pre-adolescent patient with real mild acne, perhaps you'd want to try adapalene instead because it's gentler. If you had someone with more severe comedonal acne, you might want to start with tazarotene, but I think starting in the middle is generally advised. Again, the creams are less irritating and drying than gels, though gels are, quote, stronger at the same concentration. So in this case, an apple doesn't equal an apple. Again, starting maybe a couple times a week and then advancing slowly. We always, again, want to start gentle because we can always move up. But it's hard to convince a patient who's had a bad experience with a retinoid to try it again if they have. We always want to inform patients as well that things can get worse before they get better. So because it's unclogging those pores and it's speeding up the turnover, it's going to push out the blackheads and whiteheads faster. So at week 2 to 3, a lot of patients experience what they would think is a worsening, but then if they can kind of get over that hump, so to speak, then they will remain clear. And again, we want to warn about photosensitivity, the fact they have to use a sunscreen if they're using a retinoid. And then I just added this in at the bottom. This is becoming more and more the case for many of our medications, that many of the retinoids will need a prior authorization. So we really need to advocate for the patient and do the paperwork that we need to do and check what's actually dispensed as well. Moving on to the oral medications. So for the more moderate or severe inflammatory, we mentioned oral antibiotics being first line. Oh, I'm so sorry, I skipped over this one. The other topical antibiotics that we could consider, the clindamycin is what we usually start with, I apologize, which is really our mainstay. So combining this with the benzoyl peroxide to remove bacteria off the skin so that they don't have a chance to get into the pores and proliferate. And then there's other things that we, as dermatologists, may sometimes use, really don't think they have as much pertinence in the primary care setting, but things like dapsone, which is anti-neutrophilic, and azelaic acid, which is antibacterial and anti-comedonal, again, safe in pregnancy, so that's one of the areas we use it. There are combination products that combine typically benzoyl peroxide with the antibiotic for ease of use, and of course in our adolescent population, anything that we can do to make things easier will help with compliance. So moving on to the oral antibiotics, we want to think about these when topicals are not sufficing or the person presents with moderate or severe acne where you just know the topicals alone are not going to do the job. General guidelines for oral antibiotics would include considering at least a few months trial. This is not something to do just for 2 weeks. Generally, patients need at least 2 to 3 months to see the benefit, and then they may be able to go off of the medication. You don't want to give it longer than necessary, but again, giving it enough time. The tetracycline group is usually considered first line for acne, but the key potential side effects or complications might include that these are considered teratogenic, so we don't want to be giving them without warning about that. They are contraindicated in our patients less than 9 years of age because of the dental effects. And they can all cause pseudotumor cerebri and candidiasis, though those are actually pretty rare compared with especially the candidiasis issue a lot of young women will ask about. Doxycycline is my mainstay in first-line therapy as an oral antibiotic. The dose is typically 100 milligrams twice a day, unless you have a very slender or small teenager where maybe 50 would suffice. We always want to warn about the side effect of GI upset. So because we're taking this more for an anti-inflammatory purpose, they should take it with food because that will mitigate that. Dairy, however, limits the absorption. So while they should take it with food, they don't want to down it with a huge glass of milk. If it's a choice between the two, though, I always tell patients it's better to take it than to not take it at all. And doxycycline does cause photosensitivity and sometimes quite severely, so we really need to warn about that. The cousin of doxycycline that is considered stronger would be minocycline. The dosing is very similar, but minocycline, while it may work better for severe acne, does have complications that can be severe, i.e. drug hypersensitivity reaction, which can be quite a significant allergic type reaction that can land patients in the hospital, blue-gray pigmentation to the skin with long-term use, and a lupus-like syndrome. Second-line oral antibiotics might include cephalosporins, as well as the others that I've listed there, but the tetracycline group is really considered to be best, again, because of its anti-inflammatory effect. And then I just wanted to include that, the party line really is that none of these should impact an oral contraceptive effect. Now, anything, as we know, there is not 100% benefit or safety with OCP use. So if a patient asks about that, I definitely say that even their OCP is not 100% reliable. So if they're concerned about that, they should be using a second method regardless. If I'm on the fence about a patient, should I use oral antibiotics or not, I bring it up. I ask them because sometimes it's helpful to just get quicker results, have them clear with their acne within a couple of months, and then get them on board for really continuing with the topical creams. And again, doxycycline is considered to be first line because it's relatively safe in regard to its side effect profile. Hormonal methods I mentioned, these would work to oppose the androgen effect, and we use them in girls specifically who report those menstrual flares, so ask about that. And then in slightly older teens or young women, if they have more of that lower face or jawline predominance, that can be a clinical clue, and or if they have any other signs or symptoms of PCOS. We want to be using the combination OCPs. I've listed the 3 that have FDA approval for acne. It doesn't mean, though, that the others won't work. It just means they didn't go for the FDA approval for this indication. The thing you do want to avoid, as I mentioned earlier, though, is the progesterone-only products. These definitely can worsen acne. That's listed in their product information. Spironolactone's another option that we use in dermatology as an androgen receptor antagonist. I usually use it along with an OCP or another contraceptive, however. And then I just wanted to touch on isotretinoin. This would not be something that someone would usually be prescribing in the primary care setting. It does require that both the prescriber and the patient are specifically registered in this online system. And the main reason for that is this is a teratogen for sure, and patients, young women, need to be on 2 forms of birth control if they are on this medication, and men need to be warned about not donating blood or sharing the medication with anybody. It's typically a 4 to 6 month course. It's a cumulative dose, and it has numerous side effects that we go over and warn about and monitor for very closely. So just something to be aware of. Now, some significant contraindications to considering isotretinoin or referring for that might be a lack of comprehension if the patient just really wouldn't be able to, to follow the guidelines. and or if they were desiring to become pregnant in the near future, those people should really not be considered. And then I wanted to include a slide or two on acne treatment in pregnancy because this does come up. Usually we want to take a conservative approach, but we do want to consider being more aggressive if there's scarring or if the woman has more severe quality of life impact. Topicals obviously are safer than orals in essentially all situations. And I mentioned the glycolic acid or alpha hydroxy acid washes can be helpful. Laser can also be a useful adjunct in this population. So I've listed for you there the categories of the medications that are typically used in acne, and you can see it's interesting. Benzoyl peroxide is considered a category C, though many pregnant women have probably used that medicine from the drugstore without any adverse event. So here's an algorithm for treatment in pregnancy. So starting with the mild, moderate, and severe, just for your reference. I mentioned at the beginning, not only is the acne disruptive during its active flares, but also the sequelae. So keeping in mind post-inflammatory hyperpigmentation usually can be very distressing to patients, especially with darker skin types. We want to reassure that this is not actually scar. So if it's flat and there's no texture change, that should dissipate over time. If there is actual texture change, though, then we're talking about acne scarring, which can be either atrophic, i.e. you've lost some of the integrity of the tissue, or hypertrophic, right, that you have these raised firm bumps in place. In terms of treatments for hyperpigmentation, I've listed the topicals there. I mentioned salicylic acid as a cleanser can be helpful. The retinoids can be helpful. Azelaic acid can be helpful. For scarring, really the only, for the hypertrophic or atrophic scarring, really the only thing that can be helpful there, again, are the retinoids because of their ability to improve the keratinization and collagen. We sometimes also consider things like intralesional steroid injections if the hypertrophic scars are symptomatic. So I just wanted to revisit again the algorithm here to give you that as a guideline. And of course, the caveat is teenagers want the acne gone. They want it gone yesterday, if not tomorrow. They've usually, quote, already tried everything. So you really do need to gain their trust, involve the patient in the decisions, assess their comprehension and what they're up for. What are they going to be able to do, in the morning before running off to school? I often will give specific written down instructions, and I've also included as a handout a patient form that you can give that has a lot of really good information, and on the back side has a space for writing down the specific instructions. I use a lot of analogies, i.e. we want to prevent the acne. You don't want to have any acne at all. We don't want to spot treat the bumps that you already have. Trying to encourage patience with the 2 to 3 months to take effect. So keep going, keep doing the medicine, even if you think it's not working. I want to know if you're having a side effect that's preventing you from using it, but please use it for 2 to 3 months and then let's reassess. Use a strong enough regimen as a provider. You really, again, need to gain their trust and use what's going to work best for them. Give enough of the medication and give them refills so that they don't run out. And let them know with the oral antibiotics, you are going to have to refill this after a month and go back and get more. As I mentioned, following through with the prior authorizations and all the necessary paperwork that we all have to do, and then reevaluate, every 2 to 3 months in the beginning, sooner if it's a more severe patient, and refer if necessary. So revisiting our quiz questions here, our 11-year-old girl, she has mostly comedonal acne. It's relatively mild. It's only in the T-zone. So for this young woman, I would use a salicylic acid, usually a wash, and then the topical retinoid. For the second patient, I would categorize this patient as moderate to severe, and he has most likely both inflammatory and comedonal acne, though in this picture we see mostly the inflammatory component. And then this patient already has been on a very nice combination regimen for severe inflammatory acne and not responding. So he would be categorized as having more severe nodulous cystic acne and would be a good candidate for isotretinoin. Okay.
So we have time for questions, and we'd love to hear from anybody that's joining us via the chat box, or if you're on the phone, you can chime in. So we'll give everybody a moment to ask questions.
I have a question.
Yes, please.
You mentioned that without hormonal preventing a pregnancy, if it's just progesterone only, for example, if you're using the IUD, Mirena, then you can get a breakout.
Yeah, so I see the progesterone-only implants have a much higher risk of worsening acne than the IUD.
Nexplanon.
Yes.
And what do you recommend for that?
So then we go into this kind of algorithm. I mean, you may
Just the standard one.
yeah.
Okay, I didn't know if it was anything different.
Yeah, so no, I just mean to, if you have a young woman who's at risk for acne or already has acne, that might not be the best option for preventing pregnancy, and or to warn them that may worsen their acne.
Okay.
But then, yes, you would treat with the more standard treatments.
With that, right? Okay.
We have a question from Jen Robinson. This was so helpful. Thank you. Could you talk more about dietary changes that you suggest, if any?
Sure. So controversial. I typically try to just walk the party line and talk about whole grain foods, avoiding processed foods. I bring up those two theories about milk and dairy. I really don't think that's the answer for everybody, but I don't also discourage people from trying it. I do inquire about their dietary intake in the sense that, some, especially young men, will be like drinking a gallon of milk every other day. And if that's the case, then again, sort of stressing moderation, that they don't necessarily need to cut it out of their diet completely, but perhaps want to limit the dairy intake. But there really is not, again, great scientific evidence. I mean, it's just such a hard concept to study in a good way. But I do think there's evidence. If you look epidemiologically, as a developed country and with other developed countries, our rates of acne are so much higher than developing countries. So I do think the diet is a component of that. The last thing about that too, in terms of supplementation, I've definitely seen, and it's in the literature, whey protein can worsen acne. So if you have a young man who's trying to gain weight, trying to lift weights, and build muscle, that way you might want to inquire about that, because that can be a factor in worsening acne.
Okay, another question from Lorraine Sanchez. Have you noticed a correlation of patients on testosterone blocking and more intramenstrual bleeding when a non-FDA approved OCP? Have you found it helpful to switch to YAS to single therapy to incorporate the testosterone blocking versus separating the OCP and LDAC?
Right. Yes. So Yaz and Yasmin are FDA approved. They do incorporate that androgen blocking within just that one medication, so it can be helpful. I don't find, though, that it's like the silver bullet in terms of treating everyone with hormonally based acne, and in some patients they actually report that it makes them worse. So I do think it can be helpful, but not for everyone. But it's the same concept as adding in the spironolactone or aldactone versus combining. The only benefit, I think, in my mind, of using an OCP plus the spironolactone is you can manage the spironolactone or the aldactone component better, and you have more options. Like you could go up on that dose if it's helping. I hope that answered the question.
Are there other questions out there? That was a great opportunity to inquire with our experts from UNM on this topic.
At what point do you think it's good or appropriate to refer to a dermatologist?
So I think at the moderate stage, I really appreciate when primary care doctors have already started topicals and or the oral medications, and if they've given them a few months of that and it's not working, then at that point it's very appropriate. But I would just love if people felt more comfortable with the beginning phases, and definitely the more mild acne. I think it can be managed very well in the primary care setting. But if we're in the moderate and certainly the more severe category, and the person has already tried something and it's not working, realistically, it often takes at least several months to see a specialist.
Right.
So at least starting the process, we're making the referral, but starting the whole regimen, and then that way the patient, if they need us, has already been trying something.
One thing you mentioned for acne treatment in pregnancy was around laser
Mm-hmm.
treatment. Can you talk a little bit more about that?
Sure. So laser treatments in general, though, are sort of discouraged in pregnancy, right? We don't want to do anything in pregnancy that could possibly harm the fetus. Though realistically, again, practically speaking, lasers really should not, given that they're on the surface of the skin. We use in our clinic a laser that's called the pulse dye laser, which targets redness, so it targets inflammation. And I have had some really nice success using that in pregnant women with very severe acne. You can have, rarely you can have almost like a fulminant acne presentation during pregnancy, so that can be very, very distressing for the patient. So I have had some success with that. There are other laser or light therapies that get promoted, like blue light therapy and red light therapy. Those aren't actually lasers. They're light that targets actually the porphyrins within the bacterial proliferation in the pore. So the goal is to sort of kill the bacteria through light. I don't actually have any personal experience with those modalities. They're often in sort of a med spa kind of situation, and usually not covered by insurance and quite expensive. So I can't really speak further than that, but it does get listed in the literature as an option, for safety reasons.
Thank you.
And any clinical pearls to share for rosacea that Metrogel doesn't work for?
Yeah. So Metrogel, metronidazole is a great first-line option for rosacea. I think for rosacea, similarly, it's very helpful to try to tease out what type of rosacea it is and what's bothering the patient most. So on the spectrum of flushing and redness to papules to more of the pustules kind of component. And if they're in the more pustular component, then really almost treating like acne with oral antibiotics, oral anti-inflammatories, and other topical antibiotics. If they're more in the flushing and redness aspect, azelaic acid that I mentioned can be helpful, though it can sting on application for the first few times that the patient uses it. So I always warn them that, otherwise they just stop because they hate it after a day. And then there's a new sort of area on the pharmaceutical market now is targeting the Demodex mite. So we know that the Demodex is a mite that lives in the hair follicle. It's a microscopic thing. You can't see it. It's probably on all of us. But again, the theory that people with more severe rosacea might have a hypersensitivity to that mite versus the rest of us who are walking around with it and no problem. So there's actually topical medications geared at, so ivermectin, right, that we treat for recalcitrant scabies mite, is available now topically for rosacea specifically, and sometimes people benefit from oral ivermectin, just sort of episodic dosing for more severe, but that would be again more papulopustular rosacea that's not responding to the typical stuff.
Interesting.
Thank you. There's one other product that's geared more for redness and flushing that is it's essentially topical bromodovidine. So the brand name is Mirvaso. There isn't a generic yet. but some people get around it by prescribing the ophthalmic version of bromoridine topically. And essentially that's a vasoconstrictor. It's like Afrin, or nasal, so it vasoconstricts. And so Revaso specifically for flushing and redness. Now it's a temporary benefit, so the benefit's only about 12 hours. So people put it on in the morning, and by nighttime the effect has worn off. But people really love it if they have a lot of issues with flushing, especially anxiety related, or before they're giving a presentation or something. It can just totally stop that response from happening, which is nice.
Super.
Yeah.
Thank you.
Very helpful.
Thank you.
Can we pull up the handout just real quickly just to show
Sure.
what's available to you all when you download the slides and the handouts? This is what Dr. Smith talked about a moment ago. This one, yeah.
Yeah, so this is a nice patient handout to give. So for the teenager themselves and their family, in terms of just common description and things to do and not do. This is available, here, but then also on our Society for Pediatric Dermatology website, which is pedsderm.net. And I was part of the group that vetted these handouts. So we have them on acne, we have them on other common pediatric dermatology conditions as well. And the flip side of the handout, I don't know if you can go to page 2. Here has the acne treatment plan. So I'll check off, in the morning, wash your face with benzoyl peroxide, apply clindamycin, take your doxycycline, and then in the evening, whatever else you need them to do. Wash with a gentle wash, apply your retin-A, take your doxycycline. So it can be helpful for them to look at and have something on paper as a reference to do.
Very helpful. Great. Well, it looks like we don't have any other questions, so I think we'll wrap it up. Thank you so much, Dr. Smith, for your time and excellent presentation today. And so we're going to transition now into our case consultation.